Hey y'all, this is Jessica King, a family nurse practitioner at University of South Alabama, the Johnson Haynes Jr. MD Comprehensive Sickle Cell Center. And here's my echo presentation for today. A 35-year-old African American male with a history of sickle beta null thalassemia disease who presented to the University Hospital emergency room and was admitted on April 15th for refractory stuttering priapism. He did have a past medical history of stuttering priapism, an episode which required surgery, where they did a stent or some shunting. They did some shunting and decompression and evacuation of a clot. When his conservative, but they did an injection on him, an aspiration, and that failed. That was back on April 9th. He has a history of high blood pressure, LV dilation and cardiomyopathy, thrombocytosis. He has a history of sickle retinopathy that's stable in both eyes, microalbuminuria, AVN of bilateral hips without cortical collapse, and a history of acute chest syndrome. For his social history, he lives alone, he is single, he has no children, he has a doctorate degree and works full-time as an assistant dean of student affairs at a local college. He is a non-smoker and a non-drinker. His home medications listed above. He is on hydroxyurea, Sudafed, and they've got him on Cialis. His hydroxyurea dose was actually increased from 18.5 milligrams per kilogram per day on the 9th to 22.5 milligrams per kilogram per day after that initial episode that landed him in the hospital. Interesting to note that he was prescribed previously Lyrica 25 milligrams POTID for chronic pain related to his hip, AVN in his hips, and that was started back in February. We discontinued it back on the 8th of April because he had started reporting some issues with priapism at that time. And his vital signs are listed below. Note his heart rate when he came into the ER was 142, but he was afebrile. Other diagnostic labs, his serum creatinine was in with normal limits for him, and his hemoglobin was at baseline. His UA was essentially negative. And then these here are the pre and post transfusion labs from, I'll get to that in a minute. But as you can see, he was 87.9% pre-exchange transfusion, and post he was down to 37%. On the 17th, he did have an MRI done, which also showed a residual partial thrombus of the corpus cavernosum. So his hospital course started, urology was consulted, of course. He was diagnosed with refractory priapism with a hematoma, and that was status post-shunting. There was no infectious process suspected, but they did initiate him on Keflex to prevent any kind of infected hematoma. Our team was consulted and recommended a 5-unit emergency packed red blood cell exchange transfusion. And then the course took place. He got his VASCAF by CVT and then underwent the emergency exchange transfusion. He was also given supplemental oxygen, IV pain medicine, and IV fluids. And then on the 16th, he started to develop shortness of breath. Note his VASCAF was placed in the IJ, right IJ. So he started having shortness of breath and some pain in his chest and his lungs. They did a chest x-ray and found a large right-sided pneumothorax, and a chest tube was placed. Then going back to the 17th, that's when he had the MRI where they found a partial thrombus. And then on the 18th, they did a repeat surgery with a corporal compression and clot evacuation, and they did put a JP drain in. And then on the 24th, the chest tube was actually removed. So he was in the hospital for a total of 10 days altogether. And then outpatient, he was further managed where he followed up with urology fairly quickly after discharge, and they then at that time placed him on Cialis to prevent stuttering priapisms. And then on the 30th, he came in for hospital follow-up with adult sickle cell clinic, and we continued that increased dose of hydroxyurea that we had just increased on the 9th. We continued his Sudafed 60 milligrams POQHS for prevention, and also Q6 hours PRM for acute episodes. He was also placed on a 3-month trial of Q4 week simple transfusion therapies to prevent priapism. So I guess my question, or our questions were, would you have done anything differently to manage this patient? would you continue chronic transfusion regimens?
Let's start with number one, since you so you can definitely leave the questions up there. So
Okay.
for the most part, clinical practice, we don't exchange anymore for priapism alone.
Okay.
It has not been recommended for a while. I don't know if it's specifically written out in we actually just had a conversation about this, like six of us the other day. But I haven't done that in a long time just because it doesn't work, as you guys sounds like noticed.
Okay.
I don't know about other adult providers, but I can tell you that's what, because we were talking about this on another case where there's this potential weird CNS thing that some people attribute. Who is that? Somebody
Okay.
talking?
No one was talking, but I know it has been associated with stroke. And that's why we are not doing the transfusions if we can avoid it.
Okay.
Yeah, no, it wasn't stroke. Hold on, I'm going to tell you. It's the name of a syndrome, and it's actually not a stroke.
Oh,
Um,
now he's saying Aspen syndrome. This is
that's it. Thank
sorry.
you. Aspen syndrome. Thank you. I
Okay.
could not. I was having a word finding problem.
Right.
Um, which is this. There's a case series of it. It looks like, it's acute neurologic change, but it's actually nothing seen on MRI. So I think that was the original intent of not doing it. But I think the second reason was that it just doesn't work.
Yeah, I think, initially when he came in for the previous, because he was previously in the hospital on the 9th and they did that first surgery, he did not get the exchange transfusion because they were able to, I guess, get it under control. It resolved mostly in the hospital. And then he came back with this refractory priapism. And at that time, that's when we elected to go forth with the exchange transfusion.
Yeah, so that would be the main thing I would not have done. It's really not clinically indicated.
Okay. And so, anybody else?
It's looking for some of our adult providers.
Okay.
Dr. Nelson, I see you here.
Hi, I'm here. Yes, we don't use this much. There are some promising things coming out about crizanlizumab and priapism.
Yeah, my thought too.
So
Okay.
if the patient's not on that, that might be an option.
Okay.
Yeah, the Spartan study, I think Modupe Adowu presented at ASH last year. And it's probably one of the only things we've seen well, that's not only thing. Most recent thing we've seen with crizanlizumab is some significant reduction. Though in this man's case, he may not have any more because he may no longer have function with bilateral shunts.
Mm-hmm.
The other thing it's interesting, we've been having this long discussion because of here, not about priapism at all, but about that my blood bank does not like manual exchanges and they want me to do apheresis on everybody. And I keep talking about that central lines are not without risk. So I appreciate that you gave me an example. Why I don't always want to put a VAS cath in, right? We know that.
Yeah.
But yeah, I mean, I think bilateral shunt is the most definitive way, which you've done in terms of preventing it. And if he still has anything, I would agree with Dr. Nelson. I would absolutely consider crizanlizumab.
Okay.
I have some people I've kept on routine exchanges, not simple, because hyperviscosity will increase your risk of priapism.
Okay.
And interestingly, we've sort of accidentally proven that with a lot of patients with voxelotor who got worse because of yeah, so I'd be very wary. So Dr. Purnell is saying she's had a set of 21-year-old twins with SS disease that had significant improvement with priapism with Adakveo, and Dr. Muradian is saying the same thing, an adult person using Criz. Yeah, I've had amazing results as well with Criz, all for resolution of priapism. but
Mm.
not acutely. It's not going to help you in the acute situation.
Yeah,
Really.
of course.
Or at least, let me rephrase. No one's proven that it has. I'm not sure anybody's proven that it hasn't either.
Okay.
And then
So,
in terms of terbutaline, I mean, I don't know about everybody else. I've never had any great wowed experiences. Others? Anybody? Anybody?
mhm.
I do the same thing. I mean, I give pseudoephedrine, but I don't do anything else. Dr. Pack, maybe, and I see you put something in. Hold on, I'm trying to get to it. What would I have done in the acute care setting? Pain management and supportive care and urology. I wouldn't have done anything different. Because as you guys saw, there's really no indication. There's no utility, unfortunately, in an exchange and even in a simple transfusion. It just doesn't work. So just supportive care, pain medicine, and urology, and advise on shunting. I would have done the same thing urology did. I would have said shunt.
Did you say he had a penile thrombosis?
He had a partial thrombosis in the left corporal cavernosum.
Was that unprovoked?
Well, I don't know whether you consider it provoked or not. I mean, I guess
Are you sure it was a thrombosis and not just vaso-occlusion?
that's what the MRI said.
I wonder how you definitively differentiate those.
How did you treat it? Did you was it 6 months or 3 months of anticoagulation? And did you keep him on prophy afterwards?
Okay, they did not put him on anticoagulation therapy.
Yeah, I don't think it. So I think knowing that, especially, right, if it was a real thrombosis, you would probably have anticoagulated them.
Mm-hmm.
Sounds like it was more vaso-occlusion. That's just what my understanding was.
Okay.
I don't know if the MRI would read it differently. Like, I don't know that you could read it differently on MRI. These are hard. Priapism's hard. I mean, I am excited with the potential use of crizanlizumab in this group because it's terrible when you get to this point.
Oh, yeah.
To mention something, I have a very difficult patient with a lot of recurrent priapism, and finally he was okay with compliance with hydroxyurea and pseudoephedrine, but actually urology recommended ketoconazole, and I had never heard of that, but they recommended that for about 6 months. Have you ever hear about this?
Yes.
It is
Okay.
it's an anti-testosterone. They're functionally, what's the word? Sterilizing.
Okay. And it works.
I don't know about that.
Okay. Well, he didn't take and he's okay, but good to hear that you know about it.
And that's one of the reasons why most of the patients don't really want to do the ketoconazole.
Yeah, and they're Dr. Sakakar and Dr. Pakmabian are both saying Lupron. So Lupron will do the same thing,
Mm-hmm.
but you functionally make them afunctional,
Mm-hmm.
which most people don't want.
I see. Okay.
Though I have had some patients who say they would rather not have erections than have the frequency of priapism.
Mm-hmm.
So I think it's worth offering. I'd like Lupron. I agree with those who suggested
Yeah.
Lupron better than ketoconazole. I saw the question about somebody with trait with priapism. Yes, I've been referred patients and heard about patients. With trait and priapism, but I don't know what to say about it other than I've heard of it. I don't know about others.
Mm.
Hydration is key. There's not much else to do, but hydration. In a 6-year-old, you probably could consider something hormone blocking temporarily.
Okay.
And I see a question about the role of Cialis in priapism preventative care. I've seen it both ways. I've seen it used and I've seen it make things worse. I don't know about what others said.
Well, this particular individual said that that has helped. He feels like all of the things that we are doing and urology is doing now is helped significantly. So
You mean 3 months later? Like
Yeah.
currently? Is
Yeah,
he still
currently.
is he still having erections?
Now
At all?
that I have not seen him follow up to ask that question. So that would be a good question.
Because while I'd love to say that we're awesome, I've
Mhm.
found that when you do a bilateral shunt,
Yeah.
most people don't, they're better because they don't have erections.
Mhm.
So,
Okay.
and it looks like I went back to urology's note during this admission and the clot was extracted. But I think that's a really interesting question in terms of what Yogi was asking a little while ago, which is if we really thought this was a clot, then the patient should have been treated with anticoagulation.
That's right.
You would have considered long-term prophylaxis for an, I guess, unstimulated clot, maybe. So just a
Mhm.
thought.
Mhm.
And somebody else talking about how, yes, it is possibly due to marijuana. Absolutely. There are a lot of things marijuana does that aren't good, that marijuana can induce priapisms.
Well, I know this individual patient does not use marijuana.
No, I was just seeing on the comments,
Okay.
but no, that's a really interesting case. So I'm glad it's doing better.
Yeah. Yeah. Okay. Yes, but we have had in the past, yeah, one particular person with the marijuana, but that was like a lot of marijuana.
Yeah.
Okay.
Other thoughts? That anybody wants to say out loud or instead of in the chat?
Yeah, because I can't see the chat. All I can see is my screen.
We did put the CME link in the chat, so
Okay.
feel free to get to that. But yeah, I think I'm hoping that he does okay, and I would highly recommend Adactio. Those would be my thoughts.
Okay. Okay.
And he is
All
able
right.
to have an erection. He did convey that to me, Jessica. So he
He
is
has
an erection, yes.
That's
okay, so
great.
he's functional. Okay.
Yeah, because I've seen a lot of people who after shunts are unable to, so that's great. All right. Well, that was a very interesting case. Thank you, Jessica.
Thank you.
And we will move along. I think we are going to hear from Dr. Sakalkar next. So if you want to stop sharing your slides, we can switch that around. And Dr. Sakalkar is going to talk about emergencies in sickle cell disease. He is the director of the children's group in Augusta and is a professor of pediatrics in the Division of Pediatric Hematology Oncology, the director of the sickle cell disease program in Augusta. And we are, of course, happy to have him presenting for us today.
Thank you very much, Dr. Julie Cantor. Can anybody, can everybody hear me, please?
You're a little quiet, but we can definitely see your slides.
Okay, is it better now?
A little bit, maybe just closer to the microphone.
Okay. Thank you very much. Thank you very much, everybody. And thank you very much, Dr. Julie Cantor, for giving me this opportunity to present. So it is going to be, I'm going to be a little fast, and please ask me questions in between if you would like. I'm going to be discussing on emergencies in sickle cell disease. And since there are so many of them, I'll go a little fast on the presentation. I'm having difficulty moving ahead. Oh yeah, okay. So these are my disclosures. I have some stocks which I need to get rid of, but they are unrelated to the presentation. The objectives are about trying to understand the pathophysiology, clinical presentation, and management of the different emergencies of sickle cell disease. As we know, as far as the pathophysiology is concerned, the sickle cell disease is due to the problem in the beta globin gene, which is on the chromosome 11, and on the 6th amino acid, there is the change in the amino acid from glutamic acid to valine for hemoglobin S and lysine for C. And the clinical manifestation is when the switchover happens from the gamma change to the beta chains in infancy. And as we know, it is autosomal recessive in inheritance. 1 in 4 will get the disease when each parent is a carrier, and 1 in 4 will be normal. And this was how the abnormal molecules, they will form a bond which will end up having a forming of a rod in presence of or they'll form polymerization in presence of hypoxia, acidosis, and dehydration. Also, there is a hemolysis. In this intravascular hemolysis that happens is what causes a lot of acute downstream effects and also some chronic effects due to subendothelial hypertrophy. The extravascular hemolysis causes the hemolytic anemia manifestations of sickle cell disease. So here are some X-ray diffraction slides. This whole entire thing is the our red blood cell, and which is on hemolysis, having the rods of hemoglobin jetting out of the red cell. And this is a pictorial depiction of the rods and crystals. And this is the red blood cell, which has been literally, having the crystals jet out from the red blood cell membrane. And again, this is the three-dimensional picture. So this is a artistic, depiction of the hemoglobin polymer. So there are certain organs where it is having some special reasons that can cause, manifestations of sickle cell disease. In the loop of Henle, where there is filtration, dehydration, hyperosmolar up to as much as, I believe, like 1200 milliosmoles, which causes sickling, and that the loop of Henle gets fired early, and problems in concentration of urine. Then in spleen, there is a sluggish flow causing acidosis, hypoxia. Similarly, also in the bone marrow, and in brain, due to the lack of collateral circulation, we have strokes. So here is the another pathophysiological slide here, in which you have the sluggish flow in the postcapillary venule that is shown here, and also the white cell also interacts with the platelets and causes the sickling and stasis, I would say. So, as we also know, the hemolysis due to the decreased lifespan of the sickle cells. This is the slide shows the manifestation in the tropical climates of all the hemoglobinopathies related to the malaria, and this is the sickle cell, especially manifestation, and hemoglobin S and hemoglobin C in the Ivory Coast. So coming to the major emergencies in sickle cell disease, the main ones are the fever, infectious complications, acute chest, stroke, pain episodes, splenic sequestration, and somewhat less common, but as we had a presentation right now about priapism, ophthalmic complications, especially hyphema, and others such as aplastic crisis, cholecystitis, hematuria, and other bone complications. So coming to fever in children with sickle cell disease, we and especially the parents get quite complacent because viral infections are so common, and also decreased incidence now due to immunizations, both the newer pneumococcal vaccines and H influenza and meningococcal vaccines that we routinely use, in addition to the penicillin prophylaxis, which has markedly decreased the incidence of pneumococcal infections and death due to them. But we should remember that there is about a 400-fold risk of pneumococcal sepsis in sickle cell patients, especially those who are below 5 years of age. So we should consider fever more than 38.5 as an emergency, and be very, we immediately act on it, having them go to the nearest emergency. And there they should do a quick focus exam, do some lab tests, the critical being CBC, differential retic blood culture, check a pulse ox, do a chest X-ray, and especially if the patient has high fevers and who are those who are under 2 years of age, where respiratory symptoms may be not obvious, and also those who are older than 2 years and have respiratory symptoms. You may or may not do other tests based on the symptoms the patient has. They should get parenteral antibiotics, and nowadays some institutions are using ampicillin rather than ceftriaxone. These should ideally be given within 30 to 60 minutes of the patient presenting to the ER, and we should not be waiting for the results for giving the antibiotics, and they should preferably be observed after the antibiotic therapy for 30 to 60 minutes before they are discharged. Indications of hospitalizations for fever are if the patients they appear ill or they have issues with their vital signs, if they have a really high fever, younger patients less than 1 year, significantly high or significantly low white count, low platelet counts or hemoglobin, and if they have other complications, based on the significance of those complications, they may need admission. And if they are somewhat unreliable, we may consider admitting them if we think that they may not follow up. Many other times nowadays, we do not necessarily have them follow up after 24 hours. Also, they might be fine with oral antibiotics. The other thing as we all know, we always start penicillin prophylaxis within 3 months of age of birth, and 3 months of birth, and continue it until they are 5 years of age and have had at least 1 dose of the pneumococcal vaccine. So again, coming to the next complication or emergency situation that we commonly see is acute chest, and here we have the infiltrate, and since we cannot differentiate between a infection or a infarction, they are all routinely caused as acute chest rather than the pneumonia infarction in sickle cell patients. So clinically, it is defined as a new infiltrate on chest X-ray with at least one of the following, such as chest pain, fever, tachypnea, and coughs, wheezing, rales, or drop in oxygen saturations more than 3% over the baseline in that patient. And as we mentioned earlier, it could be either infection or an infarction from commonly thought to be from fat emboli from the bone marrow infarct. And many times we have noticed that patients who are admitted for acute pain episodes end up getting acute chest due to many suspected etiologies. Then the treatment in these patients with acute chest, we almost always hospitalize patients in pediatrics, give them a broad spectrum antibiotics, a macrolide, and usually ceftriaxone, azithromycin and ceftriaxone. If they are tachypneic or low saturations, then we consider giving them oxygen. I prefer not to give them oxygen if they do not have those issues. Or if they do not have hypoxia, they may need bronchodilators, analgesics, and IV hydration and maintenance. We prefer not to, quote unquote, overhydrate them with the concern that they may worsen the acute chest. And Incentive spirometry helps these patients, and if they are quite young, then we may do some other things like bubble therapy. We help them with have them blow bubbles. They may need sometimes simple transfusion or exchange transfusion, and we try to keep the hemoglobin around 10 to 11 grams per cent. If the hemoglobin is below 9, especially below 8, a simple transfusion can be quite helpful. So the problem with acute chest is that multiple these episodes, most of them subclinical microinfarcts, as we call them, can end up having pulmonary hypertension and early death. One of the common causes in sickle cell patients with multiple acute chest syndromes or multiple microinfarcts. Primary prevention can be in those patients by we can by penicillin prophylaxis, and also pre-op transfusions, incentive spirometry, post-op, and also these have been shown to help in preventing atelectasis and acute chest with a huge study. But recently there was a study, I believe, in Europe, and I haven't followed it up, in which they had just believed in not giving pre-op transfusions and just doing hydration, and I'm not sure if that has been shown to be helpful in preventing acute chest in spite of not giving transfusions. Then also giving hydroxyurea and aggressive treatment of acute chest might help in further preventing damage. Coming to the next emergency that we commonly see is acute pain episodes. In infants especially, we see it as a manifestation of dactylitis, and they usually do have significant swellings, signs of inflammation, though it is not appreciated so much in older kids and adults. It has been shown that those infants who have had dactylitis have had worse, I would say, prognosis in sickle cell disease. Those are the patients who would especially benefit from hydroxyurea. And though we would recommend hydroxyurea in all patients of sickle cell SS, S beta 0, but these are the patients have been shown in a large study to be especially vulnerable. Coming to cerebrovascular complications, we have stroke that is seen in as much as 10% of patients with sickle cell SS or S beta 0 thal disease, and about 30% of them, as I think Dr. Kilmore, if I'm not wrong, he had presented a very nice presentation today morning on EDAS. So 30% of the patients with sickle cell may not have any stroke. They may have no neurological symptoms, but they may have silent stroke showing infarct on the MRIs. Then a lot of patients, almost 60-70% of sickle cell patients have been shown to have neuropsych changes without, and they may not have silent strokes. And so that is something it would be helpful to study in sickle cell patients. have neuropsych exams as a routine in older kids. Intracranial hemorrhage as against a thrombotic or vaso-occlusive stroke is seen in adults, quite uncommonly seen in kids, and is usually catastrophic. Uh, in stroke, what we do is do an immediate exchange with the hope of at least preventing or helping in the watershed areas. And we try to get them quickly to a hemoglobin S below 30% and keep them on a chronic transfusion with a goal of keeping hemoglobin S below 30% pre-transfusion for the first 3 years and then below 50% later, especially in those who have had who have MRA evidence of those who have either had strokes or have MRA evidence of I would say narrowing of the vessels in those patients who have whom we started transfusions for abnormal Dopplers and not strokes. So coming to prevention of strokes, we do Dopplers routinely from the age of 2 years until 16 years of age every year, and more often if those Dopplers are conditional. Then coming to the next emergency, splenic sequestration is something that is commonly seen in younger kids with SS or S beta 0 and older kids with SC and S beta plus. They usually present with sometimes not so obvious signs such as irritability, sleepiness, pallor, weakness, and they can be pretty sick and have cardiac failure and could die from sequestration, especially in kids who are less than 1 year of age. And those patients are which we are especially concerned with, and especially if the hemoglobin drops below 4 grams per deciliter in the acute situation. So as I was mentioning earlier, in SS and S beta 0 thal, the splenic sequestration can be seen as early as 3 months of age and up to 5 years. And the incidence is about 15%. In SC and S beta plus, it happens, usually happens later, usually milder, less likely to be fatal. So as I was mentioning earlier, the hemoglobin less than 2 grams per more than 2 grams per deciliter is what we define as splenic sequestration, acute splenic sequestration. And more than a drop more than 4 grams is defined as severe acute splenic sequestration. And it can be associated with, it can be spontaneous or it can be with infection and acute chest. And they can present with insidious symptoms, or they can come with shock. And it is common, especially if it is severe, for recurrence, and especially if it is severe, then it has got high mortality. The therapy usually is to immediately give them IV fluid bolus to maintain vascular volume. And the second very important thing to note is these patients, even if they have low hemoglobin, we like to give them only 5 cc per kg blood transfusion, 5 to 7 cc per kg, because the sequestered blood in the spleen usually gets released, and if we had given them a higher volume of blood transfusion, that could precipitously increase the hemoglobin and precipitate a stroke in those patients. The patients who are much younger and have had severe splenic sequestration, we should consider splenectomy in those patients. And hydroxyurea can be extremely helpful in those patients who have had mild splenic sequestration in the long term to prevent them from having a repeat spring sequestration. The next is priapism, and we just had a very nice presentation by Dr. King here. And as we are aware that in sickle cell patients, there is the priapism due to decreased blood drainage, and that is what we would call as low flow priapism. In sickle cell patients, it is defined, priapism is, when it is beyond 4 hours, that's something which is very serious. So I tell the patients and their families that if there's a persistent painful erection beyond 30 minutes, to get them coming to the ER so that they are picked up earlier and something can be done earlier in those patients. Studies have shown that it is quite common in sickle cell SS patients by the age of, before the age of 20 years, as many as 90% of them have had episodes at home for which they do not always seek attention. As Dr. Cantor pointed out, we want to immediately give them pain medications followed by hydration and irrigation, aspiration. If it is not helpful, irrigation with phenylephrine can be is extremely helpful in most cases. And we have been historically doing exchange transfusions if aspiration irrigation is not helpful. But as Dr. Cantor pointed out, nowadays we don't do it anymore. And surgical intervention is what may be helpful in those situations where it lasts too long. And in severe or recurrent episodes, impotence is something that is quite problematic and a real complication that we need to keep in mind. So for a secondary prevention, we use pseudoephedrine 60 milligrams, 30 to 60 milligrams at night, and it can also be used PRN when they have any mild priapism at home. The other drugs include hydroxyurea, epinephrine. Chronic transfusions have been used for 6 months in patients who have had multiple episodes. Sildenafil has been used, and we have also used GnRH such as Lupron and Silvestrol. I have personally not used Silvestrol. As it was mentioned earlier that crizanlizumab can also be helpful in preventing repeat episodes. I need to update my presentation on that. Coming to ophthalmic complications, hyphema is a problematic situation when they have a trauma because there is no blood supply in the anterior chamber. So sickling happens even in patients with sickle cell trait if they have hyphema, and that can block the canal of Schlemm and cause acute angle glaucoma. So in patients who with sickle cell trait, if they have pain in the eye, they should, after a trauma, they should go to the emergency, and they can do just a sickle cell prep in those situations, and urgent ophthalmology consultation may be required. And the complications in hyphema include glaucoma, corneal staining, optic nerve atrophy, and uncommonly retinal artery blockage. So they can have central retinal artery occlusion somewhat uncommonly, but has been seen in sickle cell patients. The other acute complication is retinal detachment, especially seen with, more commonly seen with sickle cell SC disease. and they need urgent ophthalmic intervention, and they also can be prevented by yearly follow-up and early intervention if they see any early complications. Aplastic crisis. Recently, CDC had issued a warning that parvovirus B19 infection has been endemic, and that sort of raised our eyebrows about in sickle cell patients. Those patients with hemolytic anemias, for that matter, any hemolytic anemia, they are more prone to aplastic crises, and these patients can have a life-threatening anemia and may need
So, how are things going there?
Uh-oh, somebody needs to mute.
Here just showing some slides showing no erythroid precursors and in patients with aplastic crisis, and here we can see some normoblasts and RBCs in the peripheral smear also. Other complications include acute cholecystitis that can present as fever, right upper pain, vomiting, jaundice. Increased direct bilirubin and ultrasound would show gallbladder wall edema, and there may be signs of biliary obstruction that can be seen, and these patients may respond to just being in PO IV antibiotics and may need acute intervention or interval cholecystectomy. Hematuria is another acute presentation that is seen even in patients of sickle cell trait, and this is due to papillary infarction necrosis, and complete bed rest is helpful in these patients in addition to hydration, and there is some controversy about alkalization in these patients. Transfusion is also indeed helpful. So there are other therapies that have been tried in patients with partial success. Then coming to the other skeletal complications, there are osteomyelitis, synovitis, Salmonella and Staph aureus are common causes of acute osteomyelitis in sickle cell patients. AVN is a chronic complication, though it may present sometimes as a acute exacerbation of a chronic discomfort. And this is a picture of aseptic necrosis that may be seen on X-ray, though MRI would be one which will help in earlier signs. So that's all I have for today, and I thought I would have some few minutes for any questions.
Yep, we have a couple of minutes. Anybody have any questions?
Let me see how I can try to get out.
I don't see any questions, but thank you so much. That was an excellent presentation. And thank you again to Jessica for presenting as well. And we will see everyone in 2 weeks. So thank you all very much.
Thank you. Thank you, everybody.
Welcome. Goodbye.